All right, so we will do just a quick welcome to everyone that has joined us for Wednesday Wellness, which is a free live educational series by Trinity Health. We are thrilled to have you all here with us as we discuss pelvic health. Before we get started, we would just like to share a few reminders. To our participants today, your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A feature, which is located at the bottom of your screen. Questions will be addressed at the end of the presentation. And lastly, today's webinar is being recorded and a link to the video will be sent to you via email in the next coming days. And without further ado, we would like to introduce you to Dr. Jannah Thompson, a board-certified urogynecologist with Trinity Health West Michigan Medical Group. Thank you for being here this morning.
Good afternoon, everyone. Thank you for the introduction. My name is Jannah Thompson. I am a physician that did a residency in urology and then went on to do a fellowship in urogynecology. So I'm a urologist by training, but special training in treating women with pelvic disorders. And I have practices in Muskegon and Grand Rapids. For those of you who may be joining, you can find me in both locations. So today is really kind of an overview of the most common things that I see. Obviously, I can't get into all the things that I see, but these are the most common reasons why someone would come to see a urogynecologist. And so sorry if it feels like the fire hoses turn on and there's a lot coming at you, but we have a lot of people on this Zoom today, and you may be experiencing different symptoms or have friends that are experiencing different symptoms. So I just want to start with some pelvic health myths that I hope to talk about today as we go through this. All right, everyone should do Kegels to maintain continence and improve sex. This is one thing that is told to a lot of my patients, and I hope to dispel some of these today. Leaking is a normal part of aging. Everyone will need adult diapers at some point. I am the only one with pelvic health problems. Most of my patients feel like that because it can be very isolating, embarrassing to talk about with friends and family. Drinking water will make me have to pee more. Surgery is my only option for leaking or prolapse. And the best way to practice my Kegels or pelvic exercises is to do it while I'm peeing or urinating. And then finally, I'm not constipated. I have a bowel movement every day. So the pelvic floor is what I consider the unknown gem, meaning that for many of us, it's just there. We don't think about it. We're not really taught about it. And we don't really understand its importance or role in bowel and bladder function. It's also very important for sexual function, and the pelvic floor does incorporate also the abdominal and the back muscles because those muscle groups help to stabilize and support your spine. And so really when that song goes, the hip bone's connected to the knee bone, it's very true when we're talking about the pelvic floor. It's not in isolation of what else is going on in your body. So I'm going to say it's underestimated and overlooked. And so hopefully I can teach you a little bit more about your pelvic floor today. So when we talk about feeling isolated alone with these pelvic floor disorders, I want those of you to know that it's actually very common. About 1 in 3 women, so 1 in 3 of the women pictured here have some kind of pelvic floor disorder. Now that can be mild to severe, but most of us are dealing with that. And I would say that in the course of our lifetime, most everybody will have some kind of pelvic floor issue. So the first topic we're going to talk about is prolapse. So what is it? Well, it is a condition that affects women. Typically, average age is 55 to 65, but I see some in their 40s. I just saw a woman in her 90s. So it can affect all age groups, but that's the primary group that when they start to notice it. About 1 to 2 women per 100,000 will require surgery. So that estimates about 200 to 300,000 women in the US. And what it is it's a stretching or weakening of the pelvic structures, specifically the vagina and the uterus. And so what women will experience is feeling a bulge, some kind of tissue coming out the opening of the vagina. Another symptom of it may be that they have to splint, which means they have to put their fingers in the vagina or around the vagina to help get their bowels or their bladder to empty. There are more non-specific symptoms that can go with it, such as pressure or leaking. But if you're just having pressure or just having leaking, it's probably not prolapse. It usually involves either a bulge and pressure, or needing to splint and pressure or leakage. So those symptoms, pressure or leakage by itself, is not typically prolapse. So what causes a person to be at risk for this? Well, it definitely, as we increase in age, we lose estrogen. We go through menopause, and estrogen is a huge factor in terms of tissue strength. So estrogen provides lubrication, blood flow, cell turnover, all those good things that we want in our face, which is why there's so many face cream products and collagen products on the market. But estrogen provides all of that for our skin, and our vaginal skin is not separate from that. So it really requires estrogen. So as estrogen leaves, the muscles of the urethra weaken, the attachment points, the ligaments, the tissue becomes stretched out. But also, being pregnant can put you at risk. Just the fact that you're pregnant has a slight increased risk. Vaginal delivery has the highest risk. C-section is not completely protected, but it is a lower risk than with vaginal delivery. And then lifestyle, tobacco use, because that affects blood flow and tissue quality, weight, heavy lifting. If you have a job that has required you to do a lot of heavy lifting over time, that can increase your risk. Chronic constipation or chronic coughing, because it's a lot of wear and tear on your pelvic floor. And then there are genetic factors that play. So many women will say, oh, my mother had this or my aunt had this. And so there may be a genetic component in terms of the collagen makeup and the strength of our tissues. So every woman's situation is unique. So what works for one in terms of how they want to treatment doesn't necessarily work for the other. So that's really, in consultation, what we would try to figure out what is the best option for you. And so these options are based on your level of bother. You may have prolapse. It may be, by some women's standards, significant, but it may not be bothersome to you. So the only reason typically to do something is if it's bothersome. Now, there's a few outlying situations where that's not totally the case, but for the most part, it's based on that. Treatment can improve quality of life, right? Because we're taking away that feeling of the bulge. It's uncomfortable, potentially taking away the need to splint, and improving sexual health. So conservative options would be, you can observe, as I mentioned, you don't necessarily have to do something about it, except in very rare cases. And physical therapy can be an option, I would say, for what I call mild to moderate prolapse. So maybe if the prolapse is just hovering inside or just sitting at the opening, physical therapy can help. Once the bulge is past the opening of the vagina, physical therapy tends not to make a huge difference. And then there's things, supportive devices called pessaries. And these pessaries are something that you would be fitted with by myself or my nurse practitioner. We have them in the office, and they basically act as space holders. So they hold whatever's coming down back up. And in this case, it's the vagina and the uterus, which I'll show you in a minute. So no single operation is right for every patient. And so there are different options for that. The type of surgery depends on your goals, not only goals in terms of what's my chance it could come back, what are my sexual health goals, what other medical problems do I have, or what would recovery look like. So all of those things play a role. This is an example of surgery. And just for a second, I would like to, hang on, go back a second. Oh, I think that slide went out of here. So I'm going to try to explain to you what you're seeing here. So this picture is showing the pubic bone right here where my cursor is, which is, so we're looking in from the side of the pelvis. This is the pubic bone, and the tailbone is back here. The bladder has been taken out of this picture, but the bladder sits right behind your pubic bone, then this tube called the vagina, and then the rectum. And if you still have your uterus, that's sitting here at the top of the vagina. Otherwise, the uterus is gone, but the vagina still persists. So what prolapse is it's a weakness of the vaginal walls. People are told it's the bladder, but it's not actually the bladder that loses support, it's the vagina. So if you think about the vagina like a sock, the toe of the sock being the uterus, or the toe of the sock being the top of the vagina after hysterectomy, it's where the toe of the sock is trying to come down and out, or the side wall of the vagina is sagging into the middle and it's coming closer and closer to the opening. So if you have a bulge, what you're feeling is the skin of the vagina. The bladder and the bowel sit behind that. So treatment, surgery, is to either wear a pessary in the vagina that holds it up, or to have surgery to the vaginal walls. So this is an example of a surgery using stitches. So this is done all inside the vagina, and it involves placing stitches here at the top of the vagina, here, between the vagina and the uterus, or if you do not have a uterus, just at the top of the vagina, into this ligament called the sacrospinous ligament, and that helps support the end of the vagina. And then typically I would place stitches underneath these side walls of the vagina to help prevent those from caving in. And whether or not you have a hysterectomy really depends on our discussion. For most women, if they're after menopause, the uterus does not weigh much, and so it does not put you at increased risk of the prolapse coming back. So you don't necessarily have to have it removed, though that is an option. Another option surgically is to go in through the belly. So instead of vaginally, this is done robotically or laparoscopically. And here I would place a piece of mesh shaped like the letter Y. So you can see this mesh, bladder sitting here, vagina's in the middle, rectum's behind the vagina, and the mesh is placed on the vagina itself, and then this arm of it comes up and tacks to the tailbone. So that's what pulls it up, back up and in the pelvis. And these repairs can have some advantages, less chance of it coming back, can be helpful depending on sexual health options and what other things are happening currently. And then another option is where the vagina can be completely closed. So where there's sutures placed in the vagina that close the vaginal walls to each other. And that's an option for women who no longer want to be sexually active and maybe have severe prolapse, and it can have the least chance of the prolapse coming back. So again, number of factors, individualized plan, but you can see there's a lot of ways to treat this problem. So we're going to switch topics now and kind of come back to that pelvic floor that I was talking about being overlooked and underestimated. So when we talk about conditions like prolapse and incontinence, there are a set of muscles and ligaments that support all of these structures. And again, here's our picture: bladder, vagina, uterus, rectum, and all of those are suspended within this muscular and ligament system. And so just like any other muscle in your body, a muscle in your arm or muscle in your leg, you can develop weakness in that muscle, or you can develop tightness or tension in that muscle. Well, when muscle tension occurs in our pelvic floor muscles, where you can actually have knots in the muscle, guess what happens? A lot of havoc can happen, right? It's chaos. The bladder can act wonky. You can develop prolapse. You can develop incontinence. And so it's not as simple as telling a woman, go off and do your Kegels. It's always a problem of weakness, because that's not the case. Many women, almost most of the women I see, it's the opposite problem, where their muscles are tight. And they need an experienced physician, first of all, to identify that. But then also they need to be sent to an experienced physical therapist. All the ones I use are women that could go in and get those muscles to relax. And oftentimes that can significantly improve or resolve incontinence. It can improve prolapse, it can improve frequency. And so that is done by massaging those muscles. So obviously it is a bit of a leap of faith to go and see a physical therapist that does this. But as I said, they're very experienced. They walk you through it step by step, let you know what they're doing and why they're doing it. And I've had so many women come back to me and say, oh my gosh, I wasn't going to go. I really, struggled with going, and then I went, and it was great. This physical therapist really helped me, and my symptoms are improved. So, what is normal? I guess before we talk about what's abnormal, we have to talk about what's normal. And normal is that urinary and bowel leakage. So leaking stool or urine is not a normal process of aging. Too many times I hear that women have been told it's because you're old, and it's sort of dismissive, and that very much frustrates me, because that's not true. It's not that, oh, I'm going to turn 70 and I'm automatically going to leak, because there are 70-year-old women that don't. And there are 40-year-old women who do. So there's a number of things that go into it. And even if aging is a part of it, you know what? There's a lot of things we can do. So abnormal is going more than 8 times a day, but it also be bothersome. Is your bladder always on your mind? Do you feel like you're not emptying? Are you planning your activities around the bathroom? Are you having to constantly think about when I'm going to drink and how much I'm going to drink, because I may have to drive in the car to my doctor's appointment 20 minutes away, and I may have to stop on the way there if I have a glass of water before I leave? And then, am I wearing pads or diapers? If all of this sounds familiar, these are not normal things. So women have said to me, when I arrive home, even if I've just urinated, I can't make it to the bathroom. I avoid drinking before I leave the house. I want to attend a family gathering or celebration, and I'm afraid to travel there either by car or airplane because of my bladder. My boss is frustrated with how many bathroom breaks I take, and it's interrupting work. I'm afraid to leave the house because I don't know when the leakage is going to happen. This could be bowel or bladder. And I know on my trip to Florida every winter where every bathroom is along the way. So 44% of patients are embarrassed to talk about these symptoms. And so these are common things I hear. These are common things that I deal with. And so if this sounds like you or a friend, there may be several things that can be done. So how does bladder control work? Well, there is a communication that's occurring between your brain and bladder that's essential for bladder control. In addition to those pelvic floor muscles, they actually are part of the signaling or the messaging that's happening between the brain and the bladder. So our kidneys produce urine, and they send it down these little tubes called the ureters into the bladder. And then the bladder slowly fills. And as the bladder fills, we begin to get that message that we need to go. That message can become more intense as the bladder fills more, to the point where it's like, oh, I got to go. Well, for many people, that communication system breaks down. They don't get that gradual sensation of an urge. They don't get sort of a warning. It's just like, oh, I got to go. And then it's too late and urine's coming out. And same thing for the bowel. The digestive system pushes our food through the intestines, and then there's signaling that's occurring between the brain and the bowel, again through nerves and muscles, letting us know when the rectum is full and we need to find the bathroom and evacuate. And again, communication can break down here in that that sense of urgency can be very intense, and your body may not wait for you to get to the bathroom before stool is coming out. And so let's talk about bowel movements. When we talk about normal, we need to talk about what that should mean. So constipation is not just how often we go, but also the consistency of the stool. So a person could have a bowel movement every day and still be constipated if their stools are really hard and they're little balls. Because of the fact that if the stool is hard, we know that the stool has been sitting around longer, and you may not be completely getting rid of it all. And so the most helpful thing for patients who are constipated is actually Miralax or some off-brand form of it that's actually pulling water into the stool. And what's nice about this over-the-counter product is you can adjust how much you take to your body. So if it makes you too loose, you just use less. The opposite, if patients are having diarrhea, or maybe not diarrhea, but the stools are too soft, or they have multiple bowel movements a day because they don't completely evacuate, one, they should have a workup by gastroenterology to make sure that there isn't a cause like an infection for the diarrhea. But then things like fiber bulking agents, Citracil, Benefiber, Metamucil, Not as helpful, I find, for constipation, more to help compact the stool together to give it more form. So those might be things that we would talk about, not only if you had problems holding your stool, but also the bowel affects what the bladder's doing. So oftentimes we're talking about your bowel habits, even if you're just coming to see me because of bladder leaking. So what is bowel leaking, or fecal incontinence is what we call it? Well, it's chronic and reoccurring. So it's not like I had it once in my life when I had food poisoning. It's something that is continuing to occur, and it's the inability to resist the urge to go. And sometimes people even pass it without knowing. So they don't get an urge and just they go to the bathroom and they find they passed stool in the underwear and didn't even know it. So that's the bowel leakage. We're going to quick talk about bladder, and then I'm going to pull the two together because a lot of the treatments for bowel and bladder are really similar. And so I first sort of need to describe to you what the problem is, and then we'll get to the treatment. So patients with bowel incontinence, put that on hold. We're going to talk about bladder. We talked about bladder a little bit, but just to be more specific, there are two main problems when people are complaining of leaking urine. One of them is called stress incontinence. This is where women leak with a cough or sneeze or lifting. And then there's what we call overactive bladder or urge incontinence. And this is where women leak when they feel like they need to go. I get home, I get out of my car, I'm watching TV, I get up from a chair, and I might feel this brief feeling of an urge, but almost as I'm feeling it, urine's coming out. Or I'm on my way to the bathroom and urine's coming out. I can't get to the bathroom in time. Key in the door. I get home and I go to put my key in the door, and all of a sudden it's like, oh, I got to go, and urine's coming out. So why these are different? So I just described two totally different problems. Now to you, you might have both, which is what we call mixed incontinence. But they're very different in terms of why they happen and what causes them. So people that leak on the way to the bathroom or with little to no warning, called urge incontinence, this has to do with functions. You can see these green arrows here. This has to do with the muscles and nerves of the bladder. Where people who leak with coughing and sneezing, it has to do with loss of support of the urethra or the outlet. And usually it's a downward force that's occurring, like I'm coughing, I'm pushing, I'm lifting, and that's what's causing leakage here, versus urge, which is the activity of the bladder muscle, not what's happening on the outside. And again, some people can have both, which is called mixed. So what causes you to leak with coughing, sneezing? Well, childbirth being a very common one, but also that loss of estrogen, as we talked about. You lose elasticity of the urethra and patency. There can be genetic component. Pelvic surgery, hysterectomy is a risk factor, or other pelvic surgeries for this. Overactive bladder urge incontinence often is associated with patients who go frequently. Now, this isn't always the case. Some people might go frequently and not leak. Some people may leak and not go frequently, or may only go frequently at night. But it's overactive bladder is a combination of symptoms that you can have one or many. And again, it would be someone going more than 8 times a day, getting frequent uncontrolled urges, feeling like they don't empty because they just went to the bathroom, and then they go on about their activities, and maybe 20 minutes later they feel like, oh, I could go again. They go back, and guess what? A little bit more urine comes out. But this isn't necessarily that you're retaining urine or that your bladder's full and you need a catheter. This is just your bladder inappropriately telling you that you need to do something about this little bit of urine that's in the bladder. So that's the problem that we're trying to get improved, is we're trying to get the bladder to hold more, take down that constant feeling of I gotta go. And so the causes for that problem are dysfunction of the muscles of your pelvic floor, orthopedic problems. So what I mean by that is I've seen a number of women with knee replacements, hip replacements. This affects the stability of the pelvis, the pelvic muscles, which then squeeze on the bladder and can lead to these issues. Pelvic surgery, structural problems with the bladder, spinal cord injury, multiple sclerosis. Many women have this problem if they have MS. and infection. So there's a number of things. And you can see that some of the reasons that we leak with coughing and sneezing can be the same reasons that we leak with an urge, but it presents differently in patients. So what are the treatments? Well, again, because the causes of these leakage are different, the treatments can be different. The only common, well, I'll get to that. So about 1 in 6 patients or people, men and women, are affected by frequency, urgency, leakage on the way to the bathroom. So you can see it's quite common, and it leads to a lot of important quality of life issues. Loss of sleep if you're up a lot at night, loss of confidence because you feel like you can't go anywhere, it's not predictable. At least I know when I cough, I maybe have to squeeze my legs together. But this type of leakage often doesn't give you a warning, or not much of one. Loss of self-esteem, and poor health. So we're first going to talk about treatments of urge leakage, and then we'll get to stress leakage. So for that irritable, overactive bladder, there are multiple things that can be done. And I put here that none of them are curative. And that can be very frustrating because the treatments for leakage with coughing and sneezing can be. But with this condition, because it's due to the function of the bladder, our treatments are trying to improve the function, but we can't quite get the bladder to work like it did when it was 18. Having said that, many of our treatments can provide significant improvement. So things that make the bladder worse in terms of behavior are drinking things like coffee, soda, citrus, spicy foods, things that are very acidic can irritate the bladder. So having most of your intake be water and maybe 2 cups of coffee or 1 cup of coffee and a glass of tea in a day, that would be sort of the right combination to minimize that impact. Physical therapy, as we talked about, bowel management, because again, if you have constipation or diarrhea, that because the bladder lives nearby, the bladder can be reacting to what's going on in the bowel. And then there's medications. Medications work on the bladder to try and get the bladder to hold more, give you more warning time. Many of them have some unpleasant side effects. Some of the newer ones are much better tolerated, and slowly but surely, we're getting better coverage with insurance companies on those. But let's say you've tried a med. Well, what else is there? Well, there's what we call advanced therapies, and these are things like Botox injection that can be injected into your bladder. That's actually done in the office and very well tolerated. And it works to kind of get that bladder to hold more, give you more warning time. There are things called neuromodulation. So neuromodulation means that we're talking to the nerves. Because remember, I said part of the issue is there's a communication problem between the brain and the bladder and the brain and the bowel. And one of these therapies called sacral neuromodulation can actually help patients who leak urine, but also leak stool. And so what's nice about this therapy is that it can be tried out and you can see what it's like before you decide to go forward with it. And so to get into a little more specifics of those therapies, as I said, here's a picture of the bladder, and here's a camera looking in, tiny camera, and I can inject it into different spots. Now, obviously, I don't inject it that many places. Typically, it's maybe 4 spots that are injected. This makes it look like there's 100, but that's not actually the case. And it has to be repeated, though, about every 3 to 6 months because the Botox wears off, just like Botox in the face. There is a small chance that people can have a hard time emptying the bladder, and very few patients have to use a catheter afterwards, but that is something that we would talk about further. In the bowel. But this one involves stimulating a nerve at your ankle that has anything to do with the bladder. But this nerve down by your ankle runs up your leg and meets up with the bladder nerve in the spinal cord. And so when we stimulate this little nerve down by your ankle, when we do that in the office, we can improve how the brain and bladder communicate. The idea is we're giving some comfortable, mild stimulation to that nerve, and it's quieting the noise coming from the bladder. So now there's more time for the brain to give the message and be in control. So these treatments are done in the office. They're done for 30 minutes once a week for 12 weeks. And then there's a maintenance program. I will tell you that fairly soon in the near future, there's likely going to be an implantable version of this where just with some numbing medication, you can place a little device down here over this nerve, and then that therapy you could have at home, and it would get rid of the need for frequent visits to the office. So hopefully by the end of this year, early next year, that will be available. Now, this is the option of neuromodulation that helps both bladder and bowel. So the first one we took, this one we looked at only helps bowel. This one helps bladder and bowel. And again, bladder symptoms specifically being frequency, urgency, or leakage with little to no warning. This is the therapy that you can try out first. So it involves a little office test where you come in and I place a little wire in the natural opening back here in the tailbone. I use lots of numbing medication. There's no risk of injuring nerves or the spinal cord. That little wire sits there near the nerve to your bladder. So instead of being way far away down by the ankle, now we're closer to the bladder. And it's only taped to you for a week. So you get to actually go home with it, try it out for a week, and just see, does it make a big difference in my bladder symptoms? Am I using way less pads? Am I having to go to the bathroom less often? And then when you come back, it's just held on with tape. So I take the tape off and the wire's out. And if you said, nope, that's not for me and never again, it's reversed. But most of the time, patients really like the response or the results. And so then we might look at the next step, which could be putting in this device permanently. That is done through outpatient surgery, where you get some anesthesia. And then the little wire that's put in is now connected to a battery. This battery is roughly the size of an Oreo cookie, and it sits in the fatty part of the butt cheek. Just kind of like a pacemaker here. This one sits down in the butt cheek, not where you sit. It's kind of up high where your pocket is. And then it's just quietly working behind the scenes to help improve that communication. So what are the results of this? Well, about 82% of patients see significant improvement. So half as many leaks. The number of pads are reduced by half. And it's improved the quality of life when we've looked at those measurements of patients who have that by 3 times the standard. So the amount, the change in quality of life that would, in which we would see a difference, it's 3 times above that. So it's a pretty significant change for people's quality of life. And then we're looking at patients who leak stool, it's almost 90% that have significant improvement in that. So these are some things patients have said to me over the years after trying this out is, you know, it's given me my life back. I wish I tried it earlier. I was able to go to my grandson's wedding. I didn't know if it worked, but I'm really glad I tried it. And there is an option even to speak with patients who've had it, if that was something you wanted to consider. So I know we're moving through a lot of stuff, but as I told you in the beginning, we're going to try to cover the most common things. So we talked about prolapse, we've talked about bowel leakage, we've talked about overactive bladder. Now we're going to talk about a very common problem, which is leaking, coughing, sneezing, laughing, lifting, called stress incontinence. And again, that's loss of support of the urethra. And so things that help here are physical therapy, where we work on Kegels if that's appropriate, or maybe you need a physical therapist that works to get that muscle not so tight and get it to relax. Most people are like, well, why would I want it to relax? Well, the issue is that pelvic muscle can be squeezing around your urethra and causing you to leak urine. And so we need to get that muscle to relax so it actually works like it should, which is relax to empty the bladder, contract to keep you dry. If the muscle is too tight or too weak, it's not doing what it's supposed to. So sometimes the physical therapy for even this problem might be that we need to get those muscles to relax, not do Kegels. Medications do not work for this problem. There are things like vaginal inserts or pessaries. Pessary was something I mentioned earlier when we talked about prolapse, but there is one that actually helps with this problem as well. And that's something that you would be fit with in the office. And then there's surgery. Many of you have probably heard of slings. They've been around for slings, as many of you may be aware, have great results. And many people come in and say, I want this sling. The issue is we have to first figure out if that is the right treatment for you, because maybe your leakage isn't this problem primarily. But a sling is a piece of mesh that sits under the vaginal wall. So here's the vagina. Above the vagina is the bladder and the urethra, and up here would be the pubic bone. So this is kind of a side view. This is sort of a front view where you're seeing kind of the hip bones over here. This little hole here is the urethra. Below it is the hole, the vagina. So what this is showing you is underneath the vaginal wall, you would place this piece of mesh so that it sits under the urethra here and supports it. Gives that little urethra some more support. Now, none of this mesh is exposed because, again, it's under the vaginal wall, but it is made of mesh, and they're very successful. As I said, they've been around for almost 30 years. We know that after 10 to 15 years from surgery, 80% of patients are still dry, and so they can be very successful. Initially, about 90% of patients are dry. So there are some patients over time that may lose effectiveness, but most continue to do well. So that is an outpatient surgery. There is a way to do a sling that's not made of mesh, but it involves using your own tissue. So it would involve a larger incision where we take a graft of tissue off of your rectus muscle or off your thigh muscle, and then that is used. I would say that typically that most people don't offer that first line because it's another big incision, longer recovery, and there can be a higher chance of not urinating, but it is an appropriate therapy for maybe patients who have certain forms of leakage or have already had a mesh sling that hasn't worked. And then the injection. So Bulkamid is a game changer. And the reason why I'm saying this is this technique, this idea has been around for a long time. Many products have been tried. It involves injecting a substance. You can see here there's a camera, and the camera goes in, and there's a little needle, and I can inject the substance into the urethra. So here, yellow bladder, urethra tube, and it creates these little cushions, which basically narrows the urethra or creates more resistance to urine coming. So here, that urethra is open. After the injection, you can see that it kind of narrows or occludes that. And so why this is a game changer is what we've had before has not been easy to inject. So this technique is very reproducible. It's easy to inject. A lot of it is because the product stays put. Other products we've used in the past, you'd remove the needle and it would just leak out. And the other important feature about this is it's non-inflammatory, so it doesn't create inflammation. Inflammation causes scar tissue. Scar tissue in the urethra isn't a great thing, particularly if you develop leakage again in the future and you need other treatments. And so these things have really changed the treatment of this problem, because prior to Bulkamid coming to the US 3 years ago, people used the injection products, but they didn't work great. And so with Bulkamid, it's being used far more often across the country. And we've really seen just the use of it go way up. So these are kind of success rates about 80%. A third of patients have a second injection, maybe because they have improvement, but they want a little top off. Maybe they have an improvement for a period of time. What we know is that in Europe, where this product's been there for about 7 to 9 years, is about a third have another injection at some point. The other important difference between this and a sling is that you're back to all your activities within 24 hours. Now, a sling has a higher success rate, but you do have some downtime where you're not doing a lot of exercise or heavy lifting for anywhere from 2 to 6 weeks, depending on which product and what physician you see in their preference. So think we'll end here and then get some questions, but just to kind of go through those myths that we talked about. Should everyone do Kegels? No, because again, some people's muscles are tight, and a Kegel is just tightening that muscle further. So sometimes that's not the best option. It might be a series of things where we work to get the muscle to relax, and then you can do a Kegel more appropriately. Leaking is not a normal part of aging. Don't let anyone tell you that. You are not the only one with pelvic floor problems. Remember, 1 in 3 of women have this. Drinking water will make me have to pee more. We didn't specifically touch on this, but many women will report this. And part of it is, having some water that has some electrolytes in it can help with the body's absorption of that. But overall, water is healthier to your bladder than things like coffee, citrus, monster drinks, because those definitely are irritating. Surgery is not your only option. As we talked about, there's other conservative things, pessaries, observation, physical therapy, medications, depending on the problem. And Kegels, to practice these while you're urinating, I would not recommend, because it confuses the bladder. So if you want to define if you're using the right muscle, you could check it out when you're urinating, but to practice that routinely confuses the bladder, because the bladder, again, is getting its signal from those pelvic muscles. And if you're contracting it, it's telling the bladder, oh, wait, I need to hold. Oh, wait, I need to empty. Oh, wait, I need to hold. And so it can, over time, make the bladder not function well. So I would not practice it while urinating it. Practice it while watching TV. Practice it while sitting in the car, while you're talking on the telephone, but not while you're urinating. And then, I'm not constipated. I have a bowel movement every day. Well, we know that people can still be constipated, again, depending on the consistency of the stool. So I know that was fast and furious, but I hope that we have a chance now for questions.
Yes, thank you so much, Dr. Thompson. As Dr. Thompson mentioned, we will now transition into our Q&A. If you have not already, please feel free to use that Q&A chat feature located at the bottom of your screen. And we are actually going to get started with a few questions that we received via email. Just a reminder, I am not clinical, so I do apologize if I mispronounce any of these words. The very first question is, what are the advantages, disadvantages, disadvantages does a hysterectomy have over the traditional hysterectomy for pelvic organ prolapse surgery?
That's a good question. So the advantages are, a hysterectomy is the picture I showed you with, let me just get to it so we're all talking about the same thing. Okay, this is a hysterectomy where the uterus is maintained and stitches are placed between the vagina and the uterus to help hold it up. The advantage is that you don't necessarily need to go through the invasiveness of removing the uterus, especially if you're after menopause, the uterus is small, you've not had abnormal pap smears, you're not having bleeding. To do this procedure, there would be less risk of bleeding, quicker recovery, less risk of injuring the ureters or another structure in removing the uterus. If you had a hysterectomy, which is also appropriate, the top of the vagina would still need to be supported. So a hysterectomy by itself is not treatment for prolapse. It might be part of prolapse treatment, but after the uterus is removed, you still need to do something to support the vagina, otherwise the vagina is going to fall. So hysterectomy is only sometimes part of it, which is why it's not a requirement or an absolute. Particularly, there are studies that have looked at the chance of prolapse coming back with keeping the uterus versus removing it. Initially, it was thought that it needs to be removed because just the weight of the uterus would increase your chance of prolapse coming back. But that actually has not been shown to be the case. There has not been a difference really in prolapse coming back in women who keep the uterus versus remove it.
Thank you very much. The next one is, does pelvic floor therapy stop the pelvic organ prolapse from getting worse?
Yes, it can. So if you, let's say you had mild to moderate prolapse, or maybe you don't have prolapse, I think physical therapy can help teach you very effective ways to not only recognize where your pelvic floor is and how to use it properly, which may help you then prevent developing prolapse, because when you're lifting heavy things, when you're having a bowel movement, when you're going to the bathroom, hopefully you're using and supporting those pelvic floor muscles appropriately. And somebody who has mild to moderate forms, if you go to physical therapy and they do massage that muscle if it's tight and or teach you Kegel exercises, many women will come back and say, hey, I'm not having the symptoms as much. I'm not noticing the bulge as much, or I'm not having to splint because that physical therapy was helpful. And so some are able to either put off further treatment or delay further treatment. Physical therapy, though, does typically require some kind of maintenance of continuing the exercises that you learn.
Thank you. The next question would be a follow-up, and it asks if pelvic floor therapy would ever reverse pelvic organ prolapse.
In mild to moderate forms, I have seen women come back on exams and the prolapse is not as prominent, or is much less obvious. So yes, I think it can definitely pull things back up, tighten things back up, in some cases to a significant degree. Other cases, it just improves it enough that maybe the bulge stays within the vagina and it's not sort of hovering at the opening as much during the day, right? Maybe now someone can go throughout their day, standing, walking, and where gravity over the day really would have had someone feel symptoms a lot towards the end of the day. Maybe now they can go through those activities and not really notice anything. Maybe they only notice a bulge when they wipe, but now they can go throughout their day and really not notice it otherwise. So to a degree, and in some women more significantly.
Thank you very much. Next question is, do you see many patients who have previously had vaginal brachytherapy for cancer? Do they have good success with any particular treatments for incontinence?
So brachytherapy to the vagina is radiation. So it's radiation inside the vagina. And that's a very tough problem because radiation changes occur to the tissue, to the vessels, to the structure, the collagen, and that effect is typically delayed. So it's usually 10 plus years from the time of radiation where some of these changes really take effect. And so there can be success with the treatments, but it is a much more difficult problem to treat because structurally that tissue has really changed. Some women can use estrogen. Estrogen cream has not been shown to cause cancer. It has not been shown to cause breast cancer. And actually, the FDA is working to remove that black box warning on estrogen cream. So many women can still replace estrogen to that tissue safely, which improves blood flow. It improves collagen. It improves cell turnover, moisture to the tissue, which can affect their continence. But other things, whether we're talking about, potentially like a bulking injection in someone who's had radiation, if they're complaining of leaking with coughing and sneezing, that would be an option. I think most of us would avoid mesh slings in the setting of radiation just because of wound healing, but maybe something like a tissue sling would be an option. And then if you're having more of the leakage on the way to the bathroom with urge, medications could be helpful, or Botox, or even InterStim, but it's a matter of trying something and seeing if it helps, moving to the next thing. So I would say it's not an abysmal or a dismal problem, but it is definitely more challenging.
Thank you very much. Our next question is implanted neurostimulation covered by Medicare insurance?
Yes, all therapies that I've shown you today are covered by insurance. There are some requirements where the insurance company has to see that you've tried some conservative things, including a medication. We need to have a diary, a bladder diary, or bowel diary on hand. But yes, most of those, all of those treatments are covered as long as the appropriate requisites, I guess, have been completed.
Thank you. Our next question is, if you leak when you're doing jumping jacks, for example, is the only way to determine if you're tight or loose is to have an exam?
Yes. Other than there are some women that will actually feel spasming in the vagina. Some of them describe it like a hot poker or a stabbing sensation, and that can often be a sign of, ooh, maybe there's something going on. But I would say most of the time it would be hard to know what that pelvic muscle is doing unless you physically examine it.
Thank you. The next question is, it's got a little bit of personal background. It says, I'm a diabetic, and I say to myself that the reason for going to the bathroom so often with no signal. How much do other medical issues affect incontinence?
That's a very good point that I'm glad you brought up, because other medical problems definitely do impact the bladder, not just diabetes, but congestive heart failure, high blood pressure, COPD, sleep apnea. All of those things affect not only structurally, diabetes can affect the blood vessels, it can affect the output from the heart. Things like blood pressure or high blood pressure, sleep apnea can affect how fluid is mobilized through the body. So yes, all of them can have an impact, but to varying degrees. So if your diabetes is well controlled, your hemoglobin A1C is within range, then you're doing what you can do to control that problem. And even though it may have had an impact on your bladder, leading up to the time where it was well controlled, there are still things that can be done on top of that, because diabetes by itself isn't the only cause. Usually it's, multiple things that are happening. But for instance, if somebody started on a diuretic, a water pill, they're going to have to go a lot more frequently. And that is going to make their overactive bladder worse. Having said that, they might find that the 4 hours after they take the med are particularly worse, but hopefully the other treatments that we bring on would reduce the symptoms the rest of the day. So yes, it's putting it all together, and it's trying to make sure that these other medical problems are managed as well as they can be. But again, bringing on these overactive bladder treatments to provide some relief.
Thank you. The next question also has a little bit of personal history involved. It says, I've experienced urination during sex, and I've had inner stim installed and removed because it did not work. I'm chronically constipated and often have to use my fingers to help myself with a BM. Would you suspect prolapse?
I would definitely have it. I would definitely recommend that you get an exam, because that could be part of it. The issue is until the constipation is better managed, having surgery anyways for prolapse, if that was a part of the problem, doesn't change the consistency of the stool. And the concern would be that the surgery would come apart. But there can be things like pessaries that could be helpful in that situation. Making sure that you've tried all of the different options that are out there for constipation, that we have you medically optimized, or that you're seeing the specialists in that field if it's gone beyond things I can help with. So yes and no. Yes, it could be a part of the issue, but there would definitely be some special considerations. And then the leakage during intercourse was the other thing. And that may, if it's only happening during intercourse, or it's happening during intercourse, but it's not preceded by an urge, it may be wise to look into more stress incontinence treatments, which may be why the interstim didn't work. It's also possible that that leakage is due to urge incontinence. And depending on when and where that interstim was placed, there may be updated techniques or other treatment options like Botox that could be helpful in that situation.
Thank you very much. We are going to try to fit in our last few questions. The next one is asking, how many hystoplexy surgeries have you completed?
Well, I've been in practice for 15 years, and it's a very common surgery that I do. So hundreds. I probably in this year, I'll have at least done 50 in a calendar year. So a lot.
Thank you very much. And how would someone go about scheduling an appointment with you?
Very good question. So you can call our office, which I should have put the slide in there at the end, but our office is at 231-672-7944. So that's 231-672-7944. You can also go online and look up Trinity Health Urogynecology, and it will come up with our number. Now, the main number where my scheduling staff is in our Muskegon office, but that same staff can schedule you in Grand Rapids if that's preferred. Typically, we need a referral, and even if your insurance doesn't require a referral, we need some kind of office notes from primary care or gynecology or whoever you've seen prior to let us know what the issue is, so that we can make sure that that seeing me is the appropriate place depending on what's going on. So usually we require some kind of office visit note. If your insurance requires a referral, we'll let you know. But usually we need some kind of information from your primary care or gynecologist.
Thank you, Dr. Thompson. And we'll also include that information in the follow-up email for everyone if they didn't get all that written down in time. The very last question that I think we have time for is, can you share some resources that I can, oh, I'm sorry. I just asked that one. I'm so sorry. Is it safe to explore an opportunity to start estrogen cream for strategy to increase blood flow in the pelvic function and decrease bladder leakage? I'm currently on HRT with good results regarding hot flashes and migraine.
Yes. So, yes, I think estrogen cream for the vast majority of women is something that they should consider and is safe to use. Now, if you've had a history of breast cancer, that doesn't necessarily mean that you can't have estrogen cream, but it depends on where in the course of your treatment, if you've had estrogen receptive positive cancer, if you're on tamoxifen. So there are some caveats, but in general, estrogen cream is replacing what we naturally have circulating in our body at a very small amount. So I don't think of it as a medicine. I think of it more like a supplement. We're giving back to you what you had either at a much higher amount or lost completely. And this is something that your primary care can prescribe for you, your gynecologist can prescribe for you. It's usually used 2 to 3 times a week, a small amount in the vagina. And even if you're on what we consider HRT, and HRT is hormone replacement therapy, typically when we use HRT, we're talking about systemic. So you're getting higher doses of estrogen, either through a patch or a pill to help things like hot flashes or mood swings. But estrogen cream can be used and often is used in addition to that, because sometimes the estrogen that we are taking through a patch or a pill, unless it's directly applied to the vaginal tissue, doesn't have the same benefit. And the benefits are many. It's shown to have a huge reduction in terms of urinary tract infections. vaginal infections. It's shown to improve incontinence. It's shown to improve vaginal dryness. It's shown to improve pain with intercourse. So yes, it has many benefits, and we all are going to lose it, all women, as we age. It's just a natural process, and so being able to provide that either back to the tissue or supplement the tissue as we age has many benefits.
All right, well, that was our last question. So thank you, Dr. Thompson, for that wonderful Q&A and your excellent presentation. We want to thank you for joining us, and we also want to thank all of our participants for joining us today. And we hope everyone has an excellent Wednesday afternoon.
Thank you all for joining. I hope that you were able to learn some things about your pelvis and how to improve just pelvic health today.